So, for example, for the nstemi is non-ST elevation myocardial infarction, acute coronary syndrome. So, the very high risk period is uh, the problem is like they have a, as I said, they have a very high risk. So, in fact, the mortality is very high. In fact, nearly like 1/6 of the patient don't make it beyond a month. Do you understand? So, in 30 days, 15% of the patient's mortality is there. So, what will happen is these are the patients. You'll notice there is more than 2 millimeters of ST depression is going to be there, and they will be having prolonged or recurrent pain. They may also have um, up to 1 millimeter of transient ST elevation as well. And similarly, hemodynamic instability can be there. They may be even having ischemia as well, in which they have been given medications and they are still not able to feel better. So, for example, coming to the treatment, what you do is you try to give them aspirin, clopidogrel, heparin, iptifibatide, or you should plan for urgent angiography. So, if they are having an ongoing pain and you're able to see some hyperdynamic changes as well, and you should prefer them for urgent revascularization as well. So then comes so what I was telling is um, about these patients. So what happens is how do you treat them? Okay, so a lot of times they may even come to you if there is a resting pain for more than 20 minutes. There's 2 millimeters of ST depression. Otherwise, there's deep T wave inversion, which is more than 5 millimeter. Otherwise, there's 2 millimeter T wave inversion in more than 5 leads. Okay, 2 millimeter, 2 is the big criteria. And of course, when you do the cardiac enzymes, they will be positive cardiac markers as well. So, for example, for the treatment, is the same aspirin, clopidogrel. Otherwise, if you want to give ticagrelor as well, you can give heparin as well. And you may also give iptifibatide. Of course, it depends upon your protocol as well, if it is available or not. And now coming to the intermediate risk patients. So, as I said it, the high risk patients, the very high risk I already showed to you, that if it is associated with hemodynamic instability, refractory ischemia, okay. Then was the high risk patients. So mortality is of course slightly lower compared to that, okay. Now coming to the intermediate risk. Intermediate risk means, for example, they are having rest pain, they are having uh, increased baseline risk in the form of diabetes, previous MI, CABG, or even recent percutaneous intervention has been done, or normal or borderline positive cardiac markers are there as well, and there's new onset or crescendo pain. So, for the treatment, what you do is give them aspirin, clopidogrel, heparin, or you can plan for a perfusion scan, otherwise, even for angiography as well. Angiography is a good test, but it has its own limitation compared to myocardial perfusion scan. Anyone would like to comment about that? That why are we thinking for perfusion scan in such kind of patients rather than the coronary angiography? Anyone would like to comment for that? Wonderful, good, good. Okay, what else? Hmm. So what else? So what happens is, um, you all are aware, coronary angiography just visualizes the vessels. Okay, so it has its own limitations as well. So we already have had lecture about the coronary angiography, so you can even go and try to Google them as well. Coronary angiography video by Narendra Kumar. You'll get those videos. So what happens? Yeah, good, good, good. Okay, good answer. So what happens is, this is more in scientific terms. Whenever we have to make fun of that, so we call it as luminogram. Luminogram is because you're trying to just see for the lumen, and that's where it comes the limitation as well. So in this sense, you are just commenting on the coronaries, but what about those microvascular, which where the contrast doesn't go? So that is where, because there are mechanisms also for the microvascular angina, and this is the reason. Yes, coronaries. Yes, you will be able to see those big vessels, and you will be able to comment about that, and you are able to do about that. Why you want to share content, Shayad Ashraf? You have always been doing like this earlier as well, again and again. Okay, so this is the reason why it is important. As I was telling you, so with a myocardial perfusion scan, you will be able to see a reversible ischemia. Reversible ischemia is meant, what it means is, only when there is areas of reversible ischemia, then you should plan for revascularization. Otherwise, if you are not, then there is no need for that at all. In fact, okay. So that is very, very important. So this is the reason a lot of setups, I would say, like especially in the Western countries, like in UK and all, we do tend to prefer a myocardial perfusion scan, in fact, rather than the coronary angiography in a lot of settings, unless until it's really acute and you're really sure, like, okay, intervention has to be planned. That's the reason, okay? So as I was telling you, for the then comes the, so we know about the high risk, intermediate risk, and now comes into the low risk. So the presentation, as it is a very short duration, and on even on EKGs as well, you have seen it's not so specific. So what you do is you can ask for cardiac markers twice at least, if they and at the most, for the treatment, if you're thinking, you can do a start them on aspirin, and you can also plan them for exercise test, stress test, in like around 48 hours. So what happens is, one of the important things is, as I was telling you, percutaneous transluminal angiography. And what is that? What is the role for that is, as you can see over here is, as you can see it over here. So early angiography and direct revascularization within 7 days, when combined with optimal medical pre-treatment, is the preferred strategy for patients with an ACS who present with signs of ischemia on EKG or raised biochemical markers at admission. So, if there is the acute coronary syndrome, okay, for the fibrinolytics, so the reason is, why are we trying to do that? Because we are trying to give plasminogen activators, and you're trying to degrade the occlusive thrombus, in fact. And when do you do that? So whenever there is a chest pain or discomfort within 30 minutes of presentation, then you do that. If there's a ischemic type chest pain, and you see there are compatible ECG changes as well, and there is a elevation of more than 2 millimeters in at least two contiguous leads. There's an associated new left bundle branch block, and there's a true posterior infarct as well. And of course, you should try to rule out if there are no contraindications at all. Contraindications. What are those contraindications? There are some absolute ones. So absolute contraindications, for example, there are no clear indications. So for example, uh, yeah, there's no specific ST elevation changes and all, and you want to do it. No, that's not good, right? So then similarly, if there's an active internal bleeding, otherwise if there's a suspected aortic dissection, there's a associated pericarditis, there's previous hemorrhagic stroke, otherwise there's other strokes within 1 year, a known intracranial neoplasm as well, you should not do. So what are those fibrinolytic agents which we try to use? As I was telling you, streptokinase. Streptokinase is normally derived from the beta hemolytic streptococcus culture, and you have to give it like 1.5 million units is given over 1 hour, in fact. And then there are TPAs, tissue plasminogen activator. So what happens is these are the naturally occurring enzymes, and of course they are much better, especially with the large infarct. But yes, they do have a high incidence of intracranial hemorrhage as well. So what you do for them is just inject 15 milligrams of IV bolus, and you have to give is at least 0.75 mg per kg over next 30 minutes, okay? And then you have to give similarly 0.50 mg per kg over next 60 minutes. There are new agents as well, like the tenecteplase, awesome one, but you have to be able to consider the weight-based dosing for that. Similarly, comes the retiplase. Retiplase is it's a genetically modified tissue plasminogen activator. But the good thing is, yes, it is not based on the weight, so you just give two boluses of 10 units at a distance of at least half an hour. Now coming to the interventional side. So as I already said it, I do already have a lecture. If you can Google with my name and coronary angiography, you'll get those lectures as well. Try to refer to that. So right now we'll try to focus our priorities about the ACS. So PTCA, you're aware, emergency PTCA, it should be done when there is a ongoing symptom. Okay, for example, for more than 12-hour duration as well. And yes, you cannot do thrombolysis, otherwise thrombolysis has already been tried and failed. The patient is having in cardiogenic shock, or there's already a previous CABG with still ongoing chest pain as well. And on the ECG as well, you saw there's active changes. And yes, you do have an access to the lab, of course. Okay, let's try to give you some case examples for this. There is a 67-year-old hypertensive male with chest pain of 8 out of 10. So the pain is radiating to down left arm into the jaw. And this is associated diaphoresis, tachypnea, nausea, and the onset has been within past 4 hours. There's no relief with nitro. And his afebrile heart rate is slightly high. The blood pressure is slightly on the higher side as well. So what do you do for such kind of patient? So the immediate assessment should include an ECG. Put them on at least oxygen. Nowadays, oxygen one is a bit debatable concept in which they are telling that they may not really need any oxygen, like unless until hypoxic actually. So in the meantime, try to take a history, examination, chest X-ray, and also try to look out for the eligibility for thrombolysis or the PCI, and even for the labs as well. You did the ECG, and this is the ECG which you get. Anyone would like to try what is happening over here? So, where's the possible infarct? So, if, yep, wonderful. So, as we may notice, there's already a ST elevation, of course. It is much more pretty more obvious in the anterior leads, and if we look, it is also extensive. Okay, one AVL as well. So it's a really big infarct, huge infarct, that's for sure. Hmm? And that is the reason you should always risk stratify them on the basis of TIMI score. What is TIMI? TIMI is thrombolysis and myocardial infarction. So you can get this apps are there. You can go online as well. You can do online scoring for that. So the TIMI score is more than 8. So what it means is it's a very high risk. So what you do is give a loading dosage of aspirin, clopidogrel or ticagrelor as well. So if you're going to give a loading dose of ticagrelor, can anyone say how much do you give? Wonderful. 180 mg. And if how much will be the normal dosage? Wonderful. Good, good, good. That's I'm really happy. Okay. Awesome, awesome, awesome. Our students are really smart. So indeed, 180 mg is the loading dosage for ticagrelor. Okay, it should really be preferred whenever you're planning for a PCI. One thing is there are some a lot of studies as well which is showing that the complication rates which is associated with ticagrelor administration is much less compared to the clopidogrel. So most of the Western countries they use only ticagrelor. Clopidogrel is pretty much outdated. And if with this, you should try to see you can think of giving sublingual NTG spray or something as well. And associated with that, if there are no associated complications or contraindications, I would say you can think of giving metoprolol as well, associated with heparin, and of course, plan for emergent revascularization study. So, what are the adjunctive treatment you have to give with that? So, as I was telling you, you have to start for the clopidogrel or even ticagrelor as well, the NTG, morphine as well. And if you're planning for a primary PCI, you can start class 2B 3A inhibitors, okay, which we already said it. So now, coming to the next example, 65-year female diabetic patient with epigastric pain. The it has just started like less than 15 minutes, and it is associated with nausea and diaphoresis. And the patient has been pain-free, in fact, right now. Okay, so uh, earlier it was like um, it started like almost 1 hour, 1/12, and now it is increasing to 4/4 or 7, in fact. So what do you do? So those basic things, important thing is of course history, chest X-ray, do a ECG, I get an immediate IV access and do a EKG as well. So these things are done. Okay, you do the ECG. What do you notice over here? Teen version, wonderful. So what will be the most likely diagnosis? Wonderful. So, so we all have already spoken about the treatment, and then you should also give adjunctive treatment as well in the form of beta blockers, ACE inhibitors, or plus minus nitrates as well, right? Then coming to the case 3. So in the case 3, what happens is, for example, there is a 37-year-old male patient. with retrosternal dull aching for 3 hours. There's no radiation, no associated symptoms, and there's history of smoking and significant family history as well. On immediate assessment, you see hmm, that. So what do you do? As I had already said, never forget the basics. Basics means IV access, EKG, targeted history and examination, do a chest x-ray, send for urgent labs with the cardiac enzymes, you get the ECG. And this is what it is. So now what do you think? nstemi. Why nstemi? Someone. So what is this ECG? Is it normal or abnormal? Okay, chest pain, yes. So why did you call it Alok? Why do you call it as nstemi actually? ECG is normal. Okay, someone said ECG is normal. This is normal. You think so normal? Start looking carefully. Start looking carefully. Always have a high suspicion. And whenever in doubt, get hold of the patient and repeat a ECG. So once you do a risk stratification of this ECG patient, so yes, you saw it seems like could be unstable angina or nstemi. So how are you going to confirm for this? That's why I was telling you. You can do a serial EKG and also an enzyme as well, at least twice, and monitor the patient. And if it is going to be normal, then you can even ask for exercise stress test, in fact. So what did you learn? So as I was telling you, there are two parts of the patients which comes to us. There's a ST elevation MI part. Okay, so why there is ST elevation? So because it is due to the thrombotic occlusion of a major epicardial artery. So you try to achieve is establish a patency and also preserve the myocardial function. And then similarly on the other side is nstemi. So in the nstemi, there is a partially occluded culprit artery or which may be even fully blocked with the collaterals, which may be associated with the ulcerated plaque and associated thrombus as well. And there is a significant risk of thrombotic reocclusion. And regarding the therapy, you all are very much aware. You have to give them some anti-thrombotic drugs and also antiplatelet drugs as well. Okay? So, about the ECG, if you all remember, it has a big role. Okay? So, if there is a ST elevation of more than at least 2 millimeters in the two contiguous leads, there is a new left bundle branch block, and there is a true posterior ischemia as well. Okay? For ST elevation emergency, you must reperfuse them. Okay? So, for example, like if there's a uh, yeah, as we already said it. However, sometimes if we did the ECG, there's a ST depression of 1 millimeter, the T wave inversion of like more than 2 millimeters, what is called as the valence pattern, okay, or dynamic STT changes with pain is there. So there will be highly likelihood of unstable angina, or even nstemi, in fact. So that is the time you should think for medical management or maybe like get an urgent imaging done as well. And yeah, if you think that uh, the ECG has been normal, the cardiac enzymes are also normal, there are not much of changes as well, that is when you start thinking that possibly the acute coronary syndrome is less likely. And then you should try to risk stratify those patients. Risk stratification, as we already said it, speaking about those TIMI scoring and all, you should try to do like that. And